Hello, everyone, and welcome to another session of Beyond the Script. And I'm here to talk to you about medication side effects. This is part three of a three-part discussion. Those of you who've been keeping up, part one, we talked about medication side effects as an overview. I gave you some general definitions, some characteristics of medication side effects. Part two, we went through two patients who had significant medication side effects, and they had quite interesting um, uh, components to their clinical illness, and that actually illustrated a lot of the different aspects of medication side effects. What I want to do today in part three is go over medication side effects. However, I want to talk to you about how Montgomery Heart and Wellness deal with medication side effects from the standpoint of preventing them. So what I'm going to do today, instead of just focusing on medication side effects, I'm going to step back and take you 30,000 feet up and give you a picture of how we manage patients overall. There's a global approach to managing patients that helps you minimize the requirement for medication and therefore minimize medication side effects. So what we're going to do is talk about the MHW approach to medication side effects. Again, it's going to start with our overall clinical assessment of our patients. We're going to review every aspect of their health and their well-being, including their medications, including their symptoms if they have any, and then we do a thorough overview. So I'm going to walk you through that process in terms of how that works. The core of what we do is we integrate a defined nutritional program with medical therapy. Many of our patients come in from all over the country, to some extent all over the world, with many advanced illnesses, heart failure, coronary disease. We have a number of people come with chronic lung disease and diabetes and liver failure. We have a number of cancer patients. So we have to look at these patients and we have to look at the overall medical condition. We evaluate the cardiac function, we evaluate the metabolic function, and we assess the nutritional condition, and then we come up with a comprehensive approach to helping them get to biochemical and physiological homeostasis. That's really the optimal goal toward achieving optimal health. And so we're going to walk you through that. So what's the overview of our process? Well, we're going to talk about the clinical assessment. So just like any patient walking into any doctor's office, whether you have specific health problems or you're going in for a regular checkup, one has to make an overall clinical assessment. That's a history and physical exam, blood markers, a test, or biomarkers, biomarker testing is done rather. That's through blood tests. Non-invasive diagnostic testing is done, and invasive diagnostic testing is done if necessary. The nutritional wellness assessment is the next step. Now, that's something that's unique at Montgomery Heart and Wellness. Most medical facilities will take you through a clinical assessment that's very thorough and then stop there. But what we do is we do a nutritional and wellness assessment. What does that mean? Well, we get insights to what your nutrition habits are. What type of foods do you eat? What type of foods do you like? And we look at those things because that helps us determine where you're starting. We will often take a food diary, often look at micronutrient testing to see what your vitamin and mineral levels are, look at your microbiome status, and so get some kind of assessment. So there's a questionnaire that you complete, and then there's a physical and biochemical assessment that you undergo so that we can get an understanding of what your nutritional status is. So that's very important. And so then there's an integrative approach that's taken. Based on the information we get from the clinical and nutritional wellness assessment, we determine what the next step is. Some people may be on a lot of medications, and we may have to fine-tune their medication list. Sometimes we will consolidate medications. If someone may be on 15 medications, we may make changes just by maybe giving one medication that we think is more effective than, say, a combination. So we make adjustments in the medication. We frequently start individuals off on a nutritional detox and cleansing program, or a combination of things. And so we also use supplements on a targeted basis. So we look at a micronutrient testing assessment. If someone's severely deficient in, let's say, magnesium and they're having some arrhythmias, then we may give them a high dose magnesium supplement in addition to magnesium rich foods. Oftentimes people may need some correction to the microbiome. A plant-based diet will help with that. Sometimes they may benefit from a probiotic. So there are a variety of things that we do to integrate the standard state-of-the-art medical therapy with the nutritional intervention. So there's an initial food prescription, as I mentioned, and sometimes there's minimally invasive tests and treatments depending on what the clinical condition is. And then, of course, there's clinical follow-up. Clinical follow-up is very important. We may see a patient as many as 3 or 4 times within a matter of 3 weeks or 4 weeks, largely because if they're on a detox regimen, we need to follow up on their clinical response. We may make adjustments in their medications as needed. So clinical follow-up can be very intense early on. And once we get our patients in a condition where they're doing well and they're stable, then the follow-ups become spread out 6 months, 9 months, yearly. Depending on how well the patients do, many of our patients, see us once a year, once every couple of years, if that often, if they're doing very well. So the overview of the assessment, I'm going to walk you through each of these categories, give you a little bit of a detailed insight as to what we do and the importance of these assessments to give you some idea. Again, although we're talking about medication side effects, the ultimate approach to minimizing medication side effects is to reduce the need of medications. The ultimate approach to reducing the need of medication is to help individuals achieve optimal health. You get to optimal health from an integrative approach, assess where your clinical status is, and make appropriate changes as needed. So without further ado, and also we're going to talk about some of our data at the end of this talk, and I do have a clinical case in point. So we're going to review one patient that we went through this process with. I'm going to show you the clinical progress that that patient made. So anyway, the clinical assessment. What's important about the clinical assessment? There are key components. The clinical evaluation of patients with complex medical problems can be very challenging. The history and physical exam remain the most important assessment of that component. Now, component of that assessment, rather. When I was in medical school, they taught us that get a good history and physical, and more the history than the physical, because if you get a good history and physical, you will get the diagnosis about 85 to 95% of the time based on getting a quality history and physical. So despite all the technology that we have today and all of the fancy tools, that still remains the case. When I talk to a patient, about 85 to 95% of the time, I have a good idea as to what the overall problem is. Now, when I say diagnosis, it may not be a specific label of a disease state, but it's a specific metabolic process. So, for instance, if I talk to someone and they have certain complaints, maybe a rash and joint pains and fatigue, I may not have a specific diagnosis, say lupus, but I will have a diagnosis of a pathophysiological process, which is systemic inflammation. And so systemic inflammatory process, lupus one of which is where we're going to start, and then we'll start working up specific diagnosis. So it's important to get a good history and physical, and we spend a lot of time on this component in the exam. The physical exam is important. You get blood pressure, heart rate, vital signs, even just looking at the patient, just in the visual inspection of the patient will give you a lot. Is the patient ill appearing rather? Is the patient short of breath? Oftentimes I'm talking to patients and they have a hard time finishing a sentence because they get winded. Those small little details are in key parts of the physical exam. How well the patient is able to walk into the office, or they're on the cane, or they're on the walker. Those types of things. The patient very talkative. Sometimes we notice, and it's particularly in female patients, they'll come in and they're not feeling very well, so they're not very made up. And once they've gone through the process and they're doing better, they'll come in, their clothes are nicer, they have makeup on. That's a sign that they're feeling better. And so we find these types of things. Men will come in with more groom, they'll be more shaved. That's a sign that they're feeling better. So we see things like grooming, makeup in men and women. There's a little bit of sign that, hey, this person, when they came in the first time, weren't as well groomed. They come in after that, they're better groomed. That's a sign itself that you pick up on the physical exam. So the important characteristics of the exam that we pick up, that's important. Biomarker testing. Biomarkers, fancy term for just labs, blood tests. When you draw blood, the blood gives you an indirect look at what's happening inside the body's organs. So, for instance, if somebody has bad chest pain and you think they may have a heart attack, we know that if heart muscle cells are dying, they leak an enzyme, CK enzyme, CKMB, troponin, and we'll draw the blood and measure for these enzymes. Now, we don't do this kind of testing in the office, i.e. heart attack screening, but there are other enzymes we draw for liver enzymes, electrolytes, and so we get an idea as to what's happening in the body. Some of these tests are more sensitive. That is, they pick up a disease state more easily. Some are more specific, meaning that their presence are more consistent with the diagnosis of a certain disease state. And some are very non-specific. But we look at all of these tests together. Oftentimes, the patient will look at the lab panel as one little test that's like 1/10 of a percent, 1/10 of a point, a unit off, and so this is abnormal. What does that mean? And so we often have to explain that it's not just one or two lab values that make a diagnosis. We look at a constellation of things. So think of it as a detective walking into a crime scene, and when a detective walks into a crime scene, they don't have a videotape of the crime with with an explanation letter of the criminal sitting there at the crime scene. No, they have a clue. They may have, a missing shoe. They may have a fingerprint. So they have to take these bits and pieces of information and put it together and reenact the crime. And so to some extent, we're doing that when we're trying to make a diagnosis or a simple clinical assessment. Non-invasive testing can be important. So let's say I see a patient and they have high blood pressure, they get short of breath when they exert themselves. I may want to do a stress test or an echocardiogram. We may do a nuclear perfusion study to look at the blood flow in the heart muscle. These are non-invasive tests that gives us information that will then further direct our decision-making process as to whether to do an invasive test or to treat with medications or by some other means. So these are important components as well. Now, there are invasive testing that we do, and we'll have to take patients to the hospital, do maybe a coronary angiogram. They may do a transesophageal echocardiogram or an electrical study on the heart, and sometimes they'll get procedures done, therapies, invasive therapies, or device implants or the like. So there's a whole spectrum that we treat our patients and manage our patients from the office to the clinical setting and also inside the hospital, even in the ICU setting. We manage our patients with this integrative approach throughout the whole spectrum of the healthcare status. So, nutrition and wellness assessment. There are critical aspects of the nutrition and wellness assessment. We evaluate the patient's view of their current health condition. Some patients come in and says, I'm in real bad shape, I really need a lot of help. That's an important differential, important distinguishing factor, I should say, because someone who comes in knowing that they're very sick and knowing that they need help, it's important that we identify this because that person may be even more motivated. That's one. Two, we need to be on the alert that that patient may be sicker than, say, some of their vital signs may indicate. So the patient's their perception of their health status is important. What is the patient's willingness to make change? That's important. The patient comes and says, there's no way I'm going to follow this nutritional regimen. There's no way I'm going to exercise. No way I'm going to stop smoking. Well, you're going to try to encourage them, but you may have to let them get to a better point of willingness before they're really ready to make changes. Because one thing we find is important, medical therapy, medical care is a partnership. Every patient I see is not a patient who follows my instruction, but a patient that partners with me, that we're going to work together to help them achieve their goals. So we don't just rely on our ability to diagnose something and prescribe a therapy. We rely on the patient's ability to, one, recognize that they have an issue, and then two, start to work to address that issue as well. We'll find out what the patient's individual goals are. Often people come in and say, well, I want to get off medications. which is what this talk is primarily about. Some people want to lose weight. Some people want to improve their, time in the marathon or whatever the case may be. All of these are important goals, and we want to help them help identify those goals so that we know where at least not only the endpoint is, but at least one endpoint is. And then we want to know what the patient's food consumption habits are. Someone who comes and eats fried chicken every day and their cholesterol is high, then that person, it may be easier to get their cholesterol down than someone who's eating, lots of vegan food that they say is healthy. It may not be as healthy as we think, but those are two different patients that we'll handle in different ways. And so knowing what their current food consumption habits are is important. So next thing we try to do is assess for nutritional deficiencies. I alluded to this earlier. There are certain conditions that may cause nutritional deficiencies. But it may be the cause of refractory health conditions. So if someone's extremely low or deficient in magnesium, magnesium and L-arginine may help with blood pressure control. Low magnesium level may be associated with sleep abnormalities or anxiety. Arrhythmias may be associated with that. So we detect whatever the nutritional status is, and then we will target supplement based on that. We don't like to supplement based on just giving someone a supplement. We like to get some idea what their deficiencies are, and then we match that to what their clinical condition is. For instance, if somebody has congestive heart failure and has some borderline coenzyme Q10 level, we will then do an aggressive supplementation of that, plus maybe magnesium or the like. The way we supplement nutrients is either intravenously or orally, or both in some cases. Some people that may have poor absorption may get oral or intravenous supplementation initially until we've gotten their gut flora corrected or gotten the gut toxicity down with maybe a juice feast or detox of some type. So we want to get idea of the patient's concept of healthy eating. What are the important benefits? It enables us to design a specialized nutrition plan. So the more we know about that individual patient, what their likes are, what their goals are, some patients are more willing to do a more aggressive plan than other patients. So we can prescribe a more aggressive plan for individuals who are more motivated or who are just ready to do it for whatever reason. It lets us customize what we're doing. It helps us improve the overall success by giving just one cookie sheet plan for everyone. It just simply doesn't work. But the more we're able to customize and help individuals where they are, it improves our overall success. So what are some of the tools? Well, we use a comprehensive food diary. Our nutritionist will come in and have patients do maybe a 24-hour or 1-week recall of the food they eat. Prospectively, let's say someone comes and says, well, I eat the healthy vegan diet. And so we may not know exactly what they're putting in. So we may give them a food diary, have them come back in 2 weeks, and we'll get a survey of what the type of foods they're eating. We may see that there's some junk food that's working their way in their diet, and that may be why their cholesterol is elevated. The wellness questionnaire, as I alluded to earlier, we try to get an assessment of where the patient is in terms of their overall wellness habits and behavior. This wellness questionnaire helps us get at that. If someone's exercising every day, that's helpful to know. They may be eating junk food and they're exercising every day. That shows that they're motivated to do something, and the exercise may help them comply with a more natural diet. What about micronutrient testing? Micronutrient testing is specialized testing. And in this slide, we have a sample of micronutrient testing done on one patient. And as you can see on the left, it measures things like zinc, copper, vitamin D3. It measures chromium, iron. There's a whole list of nutrients and antioxidants that we get some assessment for. And based on these deficiencies, we can then prescribe a regimen, either orally or intravenously, that may help them out. So integrative therapeutic approach. So how do we put all this together? Well, I like to start with a comprehensive intervention. And we start with medication assessment, optimization, and weaning. So let me give you a scenario. A patient comes in, maybe they're 75 years old, they had 3 heart attacks, they have congestive heart failure, they have diabetes, high cholesterol, they have arthritis, and they may be on 16, let's make it 22 medications. So on 22 medication, we'll review that list and determine which medications are necessary. Oftentimes, if someone's on 22 medications, they may have a lot of medications that are not really necessary. Maybe these medications are treating some symptoms or maybe side effects of other medications. So we'll assess that whole list. Maybe we'll make revisions in the doses. I'll discontinue one medication and increase the dose of another so that they're not on multiple different medications. So we try to start by removing unnecessary medications from the list. We then initiate a food prescription plan for them. Now, we're really aggressive in weaning medications with someone who is on the nutritional detox. You'll get more information about the detox in this talk. There's also some detox protocols on our site, online.montgomeryheart.com. There's a nutritional boot camp, detox, and maintenance programs that will help you with this. But suffice it to say, we start them on a detox plan, which we'll detail some here. They'll look at a food diary, assess the health goals, and start the nutritional detox almost immediately. And then the non-invasive medical treatments that's available: first diagnostic tests, echo, stress, ultrasound, vascular studies. That will help us put things together. And we'll also do some invasive therapy. So again, back to our 75-year-old patient who's on 22 medication, had a heart attack. Let's say he has chest discomfort by just walking 2 or 3 feet, and also chest discomfort at rest. Let's say he has a weak heart. His pumping function of the heart is only 25%, with normal being 50% or greater. So he has a half, normal functioning of his heart. So what do? We may have to screen him for a life vest device and determine if he can, if we can't get his ejection fraction above 35%, then he may be a candidate for a defibrillator to prevent him from sudden cardiac death. But despite just relying on a defibrillator therapy, we'll then put him through a nutritional cleansing program. We'll put him on a raw detox, and then during that process, try to wean him from his medications in hopes of getting ejection fraction up. A patient recently we saw in the office had an ejection fraction of 25%. And so he, went through the detox and did well, went through ECP therapy, and his ejection fraction at the second time we measured it was 55 to 65%. Now that was a 2-year span period. We could have measured it sooner, but we didn't. But we've have evidence that we've published, case series evidence that we've published where patients with a low ejection fraction, average 22%, was increased to 44% on average by just simply doing nutritional detoxing and improving their overall well-being. So this integrative therapy does work, is very effective. It doesn't mean that we take them off all of the medications right away, but we integrate the therapy. So the more they go up on the nutritional detox, the more they come down in the medications. And our goal is we push medications down to 0 if possible, if they optimize their nutrition over time. So these are important steps to take. Again, relying less on the medication, relying less on therapeutic interventions, and relying more on optimal nutrition and optimal lifestyle as well. We do talk to them about exercise. We do collaborate with trainers in the area. We get patients on exercise programs. We encourage them to be outside, getting fresh air and the like. So that's important. What are the details of our medication weaning protocol? We have a process, and we've actually published this, but there's a uniform approach that we take in weaning medications. And this is important because, weaning medications, there's a little bit of a double-edged sword. You can wean them too fast and have some rebound effects. Think of medication like this, especially if someone's been on a medication for a very long time. They develop what's called a dependency on it. So you become dependent on a medication when it's been there. Why you become dependent? Well, medication has chemical reactions in the body, so they may affect certain receptors, where like if the medication blocks a receptor, your body may produce less of that receptor, so that you become deficient in a certain receptor. So you remove that medication, then you may have an adverse reaction to just suddenly removing the medication. So we're careful in doing medication withdrawal or weaning in a methodical way. We start with medication we think that are unnecessary, prescriptions or supplements that people are taking that it's not quite clear why they're taking and what the benefits are. We'll remove these immediately. If someone's on insulin and they're starting a nutritional detox program, and let's say the blood sugar is in well control on the insulin, we will stop the insulin and see them within a week, check the blood sugar, have them check their blood sugar regularly. We'll give them a parameters in which they give themselves insulin. If the blood sugar goes above, say, a certain amount, they give themselves a safety amount. But typically when we do this, most people do not require going back on insulin if they follow the detox program. Week 1 changes, we tend to look at blood pressure pills. Diuretics tend to go first among blood pressure pills, and it depends on the patient's circumstances. So for instance, if the patient's on a lot of medication that's clear through the liver, and they're on a blood pressure pill that's clear through the liver, we may reduce that one first. The patient has some kidney problems, and we see that some blood pressure medicine or diuretics, if you will, that are hampering kidney function, we may wean those first. But the second week, sometimes the first week, sometimes the first visit, we may look at blood pressure pills, but definitely within that first week, we're looking at the blood pressure response to the detox program and look at whatever medication we can wean them off. Week 2, which is the third session, third time we see them, we may wean more medications. It just depends on their overall approach. Let me just give you an overview of the food prescription program. So I've given you a lot of details, and one thing I want to do, again, take you back at 30,000 feet and give you some insight. First and foremost, this is not a diet. It's a nutritional integration program. Yes, there are food prescriptions that we provide, but it's not a one-time fit-all diet. People come in and say, I want to lose weight. It's not really about weight loss. We have people come in who are pencil thin. We have patients who are emaciated with cancer, and we put them on the same nutritional regimen because it's about achieving nutritional excellence. And so it's not about losing weight or achieving some kind of special body habits. The general concepts of it is that it's a defined plan, a defined way of manipulating food so that your nutrition becomes optimized. We utilize a food prescription program, so it gives us some level of precision rather. It incorporates total removal of suboptimal foods. Now this is important because when you totally remove foods that have an adverse effect, then that's when you achieve optimal health. When we were talking about medication side effects earlier, and we are now, and the whole concept, if a medication causes either a clinical or subclinical side effect or adverse effect on the body, then we must wean that patient off and remove that medication. Ideally, you want to remove it as fast as possible. But what if you have a food that's offending you, a food that's running your cholesterol up, a food that's worsening your arthritis? That food must be eliminated. So these foods that are likely causing, high blood pressure, high cholesterol, arthritis, need to be removed, and removed totally. Not a bite, not a drop, not a crumb of these foods should be consumed while you're detoxing or at any other time that you want to maintain your health. So it also incorporates intermittent fasting. I like to refer to it as feasting, whether it's juice feasting or water feasting. It allows the body to heal and relax, and so we monitor patients in this setting. What are the objectives? Well, the objective is to halt the detrimental effects of suboptimal food consumption. That's why removing the harmful foods 100% is the most important first step that any patient takes. And then we want to assist the body in achieving biochemical homeostasis. So just think of it this way. If you had someone down and you're choking them, they're blue in the face, the first thing you would do is you'd stop choking them. You wouldn't go and put makeup on the face. That doesn't make sense. You'd stop choking them. Why? Then they start to get oxygen to the face and oxygen to the brain, and they would start to feel better. If they were about to pass out, they didn't regain full consciousness. So you allow the body to heal itself by just simply removing the offending agent. And so when we have patients who are coming in and they're on, eating bad food, fried foods and lots of beef and all this stuff, These are the offending foods of their body. And so we try to remove these offending foods to allow the body to heal and recover. We try to assist the body in achieving biochemical homeostasis, assist the body in achieving physiological balance. And the general experience is that we've had a greater than, really, the slide says 10-year, but greater than 15-year experience in having patients do better. We've actually published our work in peer-reviewed journals. I'll show you some of that at the end. And we have an ongoing optimization of this clinical intervention. So what is the food prescription system, the food classification system, and how does it work? What does it mean? Well, really, it's a system of assigning foods and other nutritional substances to categories based on their ability to facilitate optimal biochemical and physiological function. What does all that mean? That's a mouthful. In part, what we do is we give you a classification system from 0 to 10. 0 the healthiest, 10 the least healthy. The healthier foods in the lower class number, it utilizes 5 basic characteristics of the food. 1, the origin of the food. Excuse me. Is it a plant food or an animal food? Is it inorganic or mineral? Is it synthetic or not synthetic? So these are the things that we use to classify our foods. Conditions and development. Was it organically grown or was it, cultivated in the wild? How much processing was there? What are the basic chemical characteristics of the food? What are the potential effects on the human body? Is it hydrating or is it dehydrating? So these are some basic things that we look at the food, and based on these characteristics, we assign it a 0 through 10 classification level. Some classifications have subclassification to it, such as, level 4 has a 4A and a 4B and a 4C. So the classification system gives us some precision of giving you a number to food based on its health status. Now, if the food is broccoli, for instance, you say, okay, I eat a lot of broccoli. Well, how do I classify that? Well, I don't know, because it's not enough to say I eat a lot of broccoli. Was the broccoli battered and fried? If it's battered and fried, then I'll assign it to a 10. But you say, well, I'll just go into my garden, I get my broccoli and I eat it straight from the garden. Okay, well then broccoli is a level 1, so it'll get a level 1. So you know what to assign the food, not only based on what the food is, but based on what has happened to the food before you consume it. So that's the essence, a nice nutshell description of how the food classification system works. Now, why do we use it? What's the benefits of it? In essence, it provides a structured nutritional plan. It goes beyond calorie counting and portion measurement. It allows for measuring compliance. If a patient's been following 0 to 4B for a certain period of time and maybe they fall off the wagon and then eat 7+, we can quantify this percent of the time you're on 4B, 0 to 4B, this percent of the time you're on greater than 7+. It allows for evaluating efficacy of a particular intervention, meaning that if someone's doing 0 to 4B rather, at 100%, and they have, say, a 30% reduction in blood pressure, then they go back and do level 0, 100%, and get another 30% reduction in blood pressure, then we know how effective each of these food level ranges are. So it allows for some therapeutic precision. So the food classification system is a process that gives us uniformity in how we prescribe our foods, and also give us a level of precision, which allows for reproductive reproducibility from the scientific standpoint. Now, what is this prescription standpoint? Our concept is the food prescription for better health. Well, how do you prescribe food? Well, it's quite simple. We have a food prescription nomenclature, and I'll go over that with you to some extent. Now, the 2 prescription examples, as a 4-20-5-2 parentheses 0 to 4B, and then there's a 4-20-7-0 parentheses 0. So what does that mean? The first position, that's the 4 on both of those, denotes the time duration of feasting. So for instance, let's say you're going to eat for 8 hours a day, 7 days a week. You would have before, okay, that you're going to eat. So that's the time, the hours of feasting. Now, the second position, the hour of fasting. So let's say, for instance, you eat all day long, which is 8 hours, and then you've got, say another 8 hours to sleep. Then there's another 8 hours during that time that you're awake, but you're still not eating, maybe drinking water. So that position would be a 16. So you get an 8, 16. And then what days of the week are you going to eat that regimen? Well, you're going to eat 7 days a week like that. So it's a 7, and then it'd be a 0. The third position denotes the intermittent fasting. The fourth position denotes days of complete fasting. Position 5 denotes the food levels and foods to consume during the feasting period. So if you look at the fifth position, that's actually a position that's in parentheses, it tells you what food level to eat. So for instance, if we put someone on an intermittent fasting protocol, let's say, okay, we want you to feast for 4 hours a day, okay, and you're going to eat from noon until 4 p.m. The rest of the time, you're drinking water or sleeping. And so that would be a 4:20. And so we said we want you to do that for 7 days of the week. And there'll be no days of complete feasting. So then you would say a 4:20:70. But then we say, okay, what kind of food are you going to eat while you're feasting? Oftentimes, clinical teams may prescribe a patient an intermittent fasting protocol where they'll drink water all day and after 6 they'll eat, but the problem is they don't tell them what to eat after 6. So if I eat fried chicken after been fasting all day, it's really going to take away from many of the benefits I've achieved from fasting. So what you eat during the feasting period of time is very important, and it's very important that that food be healthy. And most of the times when we're doing intermittent feasting or intermittent fasting, we have individuals on a raw diet or 0 to 4B during that fasting period. So clinical follow-up, as I said, clinical follow-up is very important. Frequency of office visits, it really depends on the nature of the patient, the amount of detoxing they're doing, and how sick they are. We can do weekly visits for standard nutritional detox duration, which is 4 weeks minimum. We can do daily visits sometimes with sicker patients. Sicker patients come in that has congestive heart failure and they'll be volume overloaded. We have to give them an IV diuretic and then see them the next day. We'll put them on a detox diet at the same time and we'll adjust their medications accordingly. So sometimes we'll have to see patients quite frequently in the office, and it actually works out quite well because these individuals are actually kept out of the hospital. The food prescriptions and modifications. That's determined by clinical needs and patient preference. Patient comes in on one meal plan and they may not like something, we make changes. This helps with compliance and helps with success. And so needs and tolerances also considered. And then we make further medication optimization. We're always trying to wean or decrease medications, always. So we may do an initial detox over 4 weeks, reduce the medications by 40%, 50%. But then over time, we're always trying to minimize medication because the fewer medicines, the fewer medication side effects. So here's some of our data. The key to reducing medication side effects is the detox. We actually published in the medical literature the work we did with our 30-day detox program. We had about 31 subjects come and follow our meal plan. And we had an 87% compliance with that group. And we saw that, and this is in the outpatient setting. So this is a nutritional intervention applied in the clinical setting. So these people were coming as new patients for medical evaluation, and this nutritional intervention was applied in the context of that medical evaluation. So we were able to reduce high blood pressure, reduce cholesterol, and reduce the medications, a 40% medication reduction. Here's a picture of our population, 31 subjects, average age 53. More were female than men. There was a large percentage of Black Americans in that mean body mass index of 37.5. And they had a number of diagnoses. A third of them had coronary disease, and 27% had type 2 diabetes, a significant number had arthritis, and then about 5 of them, or 17%, had prediabetes. Here's the food classification system. This is what we use. We published this in the medical literature. but it gives some level of precision as to what we're prescribing, and it's not just any willy-nilly diet that you consume. The changes in food consumption, we looked at it, and there are a number of changes. I'm not going to bore you with the details. You can pause this lecture and look at the details. Notice there was a nine-fold increase in the amount of avocados that these subjects ate. They had a large increase in the vegetables and a significant reduction in animal protein, which was, I think, the key. We looked at biomarkers. Total cholesterol baseline was significantly reduced. The bad cholesterol, the LDL, went from 143 on average down to 118 on average. The triglycerides were improved, as well as the hemoglobin A1C and C-reactive proteins. I have these circled here. Why do I have these circled? Well, number one, the hemoglobin A1C is the average blood sugar over 3 months. And I'm showing you a study where in 1 month we showed a significant reduction in hemoglobin A1C. And so one may ask, well, how can you do that in 1 month? And this is an average of 3-month blood sugar average. Well, the other thing that contributes to the hemoglobin A1C value is fluctuations of blood sugar, okay? So if the blood sugar is fluctuating a great deal, then that will increase hemoglobin A1C. Fluctuation of blood sugar could be due to increased postprandial hyperglycemia. It could be due to the fact that someone is on a medication and they're taking maybe insulin, is driving it too low, and the body's having to increase it very rapidly. So these can cause fluctuations, or very significant fluctuations in the blood sugar, and that's probably what's contributing to an increase in the hemoglobin A1C. So what we find that introducing a plant-based diet, this problem is corrected likely. Blood pressure, we see a reduction in systolic, diastolic blood pressure. As I mentioned earlier, reduction in cholesterol. So we already see here the patient started at a baseline of 2.6 medications. And it went down to 1.6 medications per patient. So let's look at the clinical evidence. Another publication of ours showed that we were able to reduce lipoprotein a. This is considered an atherogenic molecule that can predispose to heart attack, maybe even stroke. So this was reduced, and your risk for those things were reduced as well. So what are the general biochemical effects? As we've shown before, and this is it again, 15% reduction in LP(a), total cholesterol, LDL cholesterol is reduced, inflammatory markers are reduced. So there are many different adverse molecules that are reduced to the biomarker setting, and we're able to measure these changes over time. And this data here represents about 200 subjects. Excuse me, it represents 31 subjects, but it's been reproduced in thousands of subjects and published in some local meetings in the numbers of 200. Here's some more data from our studies. LP(a), you see the numbers here. I won't bore you with all the details, but it's suffice to say that we had very significant reduction in these biochemical biomarkers, and that gave us the potential of making medication reductions and the like. Notice the CRP, higher sensitive C-reactive protein, is a marker of inflammation. They went from baseline at 7.8 down to 5.4. That was a greater than 30% reduction, really important. So you see major reduction in some of these other parameters. White blood count, which was normal at baseline at 6.3 on average, went down to 4.8, so it became more normal. But this is something we need to be on the lookout for, but patients will start to get systemic illness, and the white blood count, which may start off at 2 or 3, may go up to 9. And so 9 is still within the normal range, but 9 is abnormal for that patient. So, we look at these things, and so 6.3 may have had a number of white blood counts that may not have been biologically normal. So let's look at a clinical case report. This is a 60-year-old man who came into the office with shortness of breath. I remember when he came in, his primary physician actually had called me that day and asked if I would see him that day, and I said sure. We got him checked in, and he came in, and his heart was beating really fast, 122 beats a minute. He was short of breath, swollen all over. And so I said, look, we can do some outpatient workup, but it'd be best if we put you in the hospital. I can do a lot that's much faster. He agreed, and so he was admitted with shortness of breath and volume overload. So here he had lower extremity edema on the right and the left. The EKG, I'll show you later, showed atrial flutter. He had a very fast heart rate. So he needed to be admitted to a hospital, admitted to one of our local hospitals, and to determine how he was doing. So this is a classic counterclockwise atrial flutter with a rapid ventricular rate. And that's something that you can see in individuals who are systemically ill or who has simple benign atrial flutter. What was the kidney function? So the kidney function improved. So day one is when he saw us and we put him in the hospital. Like I say, we integrate our therapy wherever the patient is. So we put him on a raw detox diet in the hospital. So we know that his GFR, glomerular filtration rate, improved over time. And that's a sign that the patient's kidney functions are getting better. The creatinine, that number went down, which is important because a creatinine that's high means that you're not clearing this protein from the blood, which could be a sign of the kidneys not doing their job. So what happened to the patient? So he came in and he had a very low albumin level. Now notice that an albumin is a molecule, it's the major protein that's measured in the blood. So individuals often will come in and say, well, I was told I need to get more protein in. They mean more dead animal flesh so I can get my protein up. Well, here's an example of somebody who was already eating the standard American diet, already eating the dead animal flesh. But despite that, he had a low albumin. His protein was low. So we put him on a smoothie feast with some raw salads and so on. And while he was in the hospital, his albumin level went up to almost normal, for us normal. So it went up significantly. But then after he was discharged, it was around the holiday season, I remember this, he ate a bowl of oyster soup. Had maybe 2 spoonfuls, started feeling horrible, had to be readmitted. Notice his albumin after eating the animal protein food, that he started having a decline in the blood, in the albumin level. So the albumin was leaking out. It wasn't because the liver wasn't making any, it was leaking out. And the inflammation triggered by the oyster soup likely caused an acute inflammatory condition, which caused the albumin to leak out. He started to develop fluid in his lungs, and we eventually had to readmit him. And so when we readmitted him, his albumin went up because we put him on a raw detox diet while in the hospital. So the raw detox diet does wonders to help with the blood sugar control, and it also decreases inflammation, allow the body to heal itself. As you can see here, one thing I want to point out is that the albumin always went up when he was on the raw plant-based diet, not when he's eating meat on a regular basis. So clinical outcome with intervention. Summary, greater than 50% medication reduction was seen in this patient. We had a correction of the overall heart rate. We got the rate control and eventually the rhythm under control. We corrected his leg edema with not only the nutritional intervention, but he came back with some leg edema due to venous insufficiency. We addressed that problem. His albumin level improved and total protein level improved. And we're going to work on, excuse me, the improvement in overall clinical well-being on the patient. So the key is to work on treating the patient globally, not just prescribing this medicine or that medicine, but treating the patient globally. We managed this patient by looking at his overall health condition, looked at his medication list, and what we did is that we minimized certain medications, put him on a nutritional detox, minimized other medications over time, and we observed him getting better. So there was an improvement in overall clinical well-being, not just the suppression of symptoms. There's a difference. When you go in a typical clinical evaluation, the blood pressure is high, you get a blood pressure pill, blood pressure comes down. That's not necessarily overall clinical well-being improvement. That's just getting a pill for elevated blood pressure, getting the blood pressure down, and that's just the treatment of a symptom. So I just want to highlight this last sentence as much as I can because I think it's very, very important in this overall discussion. So, final thoughts. Although I went through a lot about clinical assessment, the take-home message is optimal health results in minimal medications. Optimal nutrition potentiates optimal health, which then supports minimal medication. As you saw in our overview, we take a global approach to the patient's health and well-being. We then take that, apply a treatment, includes a food prescription treatment, but it may include other integrative therapies such as, treatment for heart failure or something like that. And then once we've done that, we continue to further wean medications. After our initial assessment and weaning, we further wean medication to the point that the patient's either at zero medication or minimally tolerated medication reduction. But we're always trying, and this is a key, in my opinion, to minimize medication side effects. Not only does it help minimize medication side effects, but it also helps to reduce the initial problem, which is the primary condition. This approach helps improve heart condition, improves eliminates diabetes, eliminates high cholesterol. So it improves your health in a global fashion to eliminate the need for these medications. So you're really getting a double bang for your buck. So again, thank you for your time and your attention. I know this was a long talk, but I gave you a lot of information. You may review this talk in the future if you want to take notes. I try to go slowly through some of the slides so you can take notes with some of the slides. But there's a lot of information. This is our global approach. And again, to learn more about who we are, go to montgomeryheart.com. You can also go log on to our digital wellness center. It's online.montgomeryheart.com, online.montgomeryheart.com. And also, please subscribe to this channel. We have a lot of information that we'll be sharing with you over the weeks. And I look forward to visiting with you on some of the future live sessions as well. So anyway, until next time, the best to your best health.